Welcome everybody. My name is Dario from Concept Medical, and we are sorry for the little late, but we are waiting that Professor Colombo is joining. He's having a little bit of late, but I want to introduce you the session of today that is very important for us. The topics are the experiences, tips, and tricks with the MagicTouch, that is Concept Medical Sirolimus coated balloon. With us in this moment, we have Manish Doshi, the president of Concept Medical and the founder, and Dr. Sandeep Basavarajaiah for his experience. It will be one of the speakers of today. I want to thank you all from different parts of the world, and I will give you some technical aspects that we can use during the webinar, just to let you interact with the speakers. On the right side of your screen, you have a couple of boxes called questions and chat. Once you have a question, you can report this question there, just to let us know you need to ask something. And once we have pauses between the different topics, we can allow you to also speak directly on your microphone. So you can write who want to talk, and we will activate the microphone to let you speak, let you ask directly the question. I want to introduce our President Manish Doshi, that want to spend a couple of words for all of you. Thank you for your attention, and enjoy the webinar.
Thank you, all the friends. Thank you for showing interest in this webinar. Believe me, we designed this technology with one passion, and we were first to develop Sirolimus coated balloon, because everyone knows that Sirolimus requires something different technology. Now, I would like to even invite Dr. Sandeep Basavarajaiah and Professor Colombo. Unfortunately, is getting connected very soon. And what I love Professor Colombo. He's a good friend. He's a good mentor, and I have seen in last 20 years he has designed, created a new techniques, and you people will be happy to know Dr. Sandeep Basavarajaiah is one of the fellow Dr. Colombo. So and Sandeep, Dr. Sandeep has a large experience with drug-coated balloon, having paclitaxel, and since last few years now he loves the MagicTouch Sirolimus coated balloon. Excellent cases, good approach, excellent operator. So this is going to be a combination of Professor Colombo and Dr. Sandeep, one in UK and one in Italy. And this is going to be a very good education session, I believe, because I love always to learn, understand techniques from Professor Colombo and Dr. Sandeep. So believe me, this is going to be a good learning session, this webinar. So I would like to now invite Sandeep to get started with his talks.
Thank you, Manish. Welcome, everyone. We're still waiting for Dr. Colombo. Obviously, he will join as soon as he comes. Obviously, we had the agenda was that he's going to start with clinical indications for DCB, and then I would have gone on to do the technology of MagicTouch. But because we are slightly running late, so I'll probably start with my lecture, and then obviously when he comes, he can show his presentation. So, as you all know, I've been introduced. My name is Sandeep Basavarajaiah. I'm a cardiologist in United Kingdom. So I work in Heartlands Hospital in Birmingham. So in this lecture, I would like to give you the technology of MagicTouch and also what are the potential advantages of it over a paclitaxel coated balloon. Just to check, Dario, can they all see my screen?
Yes, it works. You can move. Yeah.
Okay, so right. So as you all know, currently we have two kinds of DCBs. The paclitaxel coated balloon, which has been around for more than 15 years in clinical practice. The Sirolimus coated balloon is relatively a new technology, which has been in Europe since last 5 years. It obtained its CE mark in 2016. So just going by the, just a DCB, just going by the advantages of the drug itself, what are the advantages of Sirolimus over paclitaxel? Most of you know this, but I would like to take you through some of the known benefits of Sirolimus. So for example, it boils down to the physical properties of the drug. So the mode of action, Sirolimus is more friendly towards the cells because it has a cytostatic properties, whereas paclitaxel is a cytotoxic drug. So it inhibits the cell proliferation by killing the cells, so by inhibiting the mitosis within the cells. If you look at the margin of safety, it is much higher in Sirolimus as compared to paclitaxel, and hence the therapeutic window is much wider in Sirolimus as compared to paclitaxel. In addition, paclitaxel only has anti-restenotic properties, whereas Sirolimus also has anti-inflammatory properties. And hence, we have seen in stents, the current generation drug-eluting stents are all based on limus. It could be Sirolimus or its analog like everolimus or a zotolimus, and we don't see paclitaxel-based stent anymore in clinical practice. And that's because there is a strong evidence of Sirolimus over paclitaxel in the clinical practice. In addition, obviously, there was a concerns raised a couple of years ago following an article by Cazzano in the peripheral intervention that use of paclitaxel device, either a stent or a balloon in peripheral arteries resulted in higher mortality were treated with a balloon angioplasty. And this created a lot of panic, especially in peripheral intervention, although this has not been shown in the coronary intervention by the publication by Bruno Scheller. But certainly there is some concerns of a toxicity. Maybe in the peripheral intervention, the balloons are longer, so there's more drug on the balloon. And maybe there is more stasis of the drug as compared to coronary circulation. So there's probably enhanced toxicity in the peripheral circulation. Despite all this, we can ask ourselves, how come the Sirolimus balloons were never invented or designed? Because there's issue with the Sirolimus, again, boils down to the properties of the drug. So although Sirolimus has got excellent property in terms of mode of action, margin of safety, but when it comes to the tissue absorption and retention, it's quite poor because Sirolimus is a poorly lipophilic drug, and hence to transfer it to the vessel wall is very difficult. And also, once it goes into the vessel wall, the tissue retention is very short. Unlike paclitaxel, which is a highly lipophilic drug, it goes straight into the vessel wall upon contact from a balloon surface into the intima. And obviously, it is retained in the tissue much longer. So, which is why we have seen so much paclitaxel-coated balloons in clinical practice. So the challenges in designing a Sirolimus-coated balloon is to enhance the tissue absorption. So to have some kind of glue or a carrier which takes the drug into the vessel wall. And once it's in the vessel wall, we also have to have some kind of mechanism where there's a reservoir of this drug being slowly released into the vessel wall. So this has been now achieved by the Concept Medical balloon called MagicTouch, which is a Sirolimus-coated balloon, by using a very unique technology called Nanolute. And I'll take you through this in the next few slides. So what they have essentially done is they have broken the Sirolimus particle into sub-micron particles. So these are very, very tiny particles. So the risk of embolization is very small. Even if it embolizes, it gets distributed into the circulation through the capillaries as it goes through them, unlike a macroparticles of paclitaxel. And then these are encapsulated in a phospholipid biocompatible carrier. So this phospholipid is basically lipophilic. It goes into the vessel wall. So these sirolimus are encapsulated in this particle, which are then spread evenly over the balloon surface and then delivered into the vessel wall. And this is a scanning electron microscopic image, which essentially shows that the drug is uniformly coated on the balloon because it is sprayed once the balloon is inflated. So if you look at the way that it's done, they inflate the balloon at a low pressure, then spray the drug. So it's uniformly coated, so there is no loss in the folds. Then it's refolded, and then we use in the clinical practice by reinflating it when delivering the drug. And that's the reason why you see more uniform coating of sirolimus with this kind of technology. And if you go back in detail to the actual particle, so this is the sub-sirolimus particle with an encapsulated phospholipid carrier, which has the two excipients, one which takes into the vessel wall. The second excipient basically is a calcium phosphorus substance, which gets broken as the pH changes within the vessel wall, releasing the sirolimus. And this is an excellent slide from an animal study conducted a few years ago, which essentially shows that the concentration of sirolimus after a 60-second inflation of a MagicTouch in the blood and also in the tissue. So if you look at the blood concentration, within 30 minutes, you get a very high blood concentration as expected. But within 24 hours, the level comes down to very minimal. So essentially, it's metabolized very quickly, or it's gone from the system. Whereas the tissue concentration is high because it's a local delivery drug, and you could see even at 7 or 8 days, you still have a decent amount of tissue concentration, and even at 14 days. And this is one of the reasons why we can stop a dual antiplatelet therapy within a month after treating a DCB. And this is another animal study showing the distribution of the drug over time into the vessel wall. So this is a fluorescent labeled sirolimus drug, which when inflated in the lumen, so this is the lumen and this is the media and this is the internal elastic lamina. You could see within the first hour it stuck onto the internal elastic lamina, but at day 3 you could see the diffusion of the drug into the media, and it's now mostly in the inner side of the internal elastic lamina and also some in the media. But 7 days, the drug is in the media and also into the adventitia, reaching beyond the external elastic lamina. So the drug goes quite deep into the vessel wall within 7 days. This is just a schematic I have prepared just to kind of reiterate what I just said. So this is your lumen, this is your media and adventitia, this is your guide wire, and this is your inflated sirolimus balloon, and that's your plaque or a ISR. Once inflated, the sirolimus balloon subparticles, which are basically encapsulated phospholipid carrier, goes into the media, and then obviously you take the balloon out, and after that the sirolimus is slowly released into the media, and the phospholipid carrier is a biocompatible, it gets metabolized, and then obviously the sirolimus then acts to reduce your ISR or a plaque burden. So in conclusion, so the drug we know is quite safe. It has been proven for over 2 decades now, sirolimus. The carrier is a phospholipid biocompatible carrier, and the coating is done in an inflated state of a balloon so that it's more uniformly coated. And obviously the technology is a nanotechnology, so these particles are very, very tiny, so which means the risk of embolization is small, and even if it embolizes, it gets into the arterial capillaries and gets thrown out of your heart, unlike a macroparticles where it can cause slow flow and other problems, which has been well documented. Coming to the actual balloon, it is a semi-compliant balloon with an excellent delivery because so far we have not seen any balloons wasted within 2 minutes starting at the Y connector. Even for the distal vessel, we are able to deliver this balloon very nicely without any problem. And the inflation is 60 seconds, but you can do a stepwise inflation, especially if there's a hemodynamic compromise if you're treating a proximal vessels. And the drug dose is 1.27 microgram per millimeter square of sirolimus. And as I said, the drug carrier is a phospholipid carrier. So in conclusion, Sirolimus offers advantages of paclitaxel. It's a well-known fact, the drug itself. But obviously on a balloon, there is a lot of robust clinical trial going on comparing the two technology, which will give us an answer whether it is better than the paclitaxel. Challenges of Sirolimus delivery and tissue retention have always been an issue, but this has now been addressed by the nanotechnology by Concept Medical, and we do have an excellent balloon called MagicTouch. An ongoing robust clinical trial will confirm its clinical efficacy. Thank you.
Thank you so much, Sandeep, for sharing your experience. For sure, this is a good perspective by your side that you are every day on the cath lab and you experience each day the product. We know that you are one of the best users in Europe right now with many cases that in the next upcoming minutes you are going to show also as experience. But as we have the honor to have here the inventor of a MagicTouch, that is Manish Doshi, we can use this opportunity also while we are waiting for Dr. Colombo to have some additional points that can make the difference in all the between the other DCB. I invite also the audience, in case of additional request, technically speaking, or in general curiosity you need to have, to not hesitate to write down on the question boxes some aspect, or on the chat we can give you the words just to directly asking this point. So Manish, would you like to add something in addition to what Dr. Sandeep has given? Because I think that you are the ones that, as an inventor, know all the things behind the curtain. So it will be really super to have this additional information.
Thank you, Dario, and thank you, Sandeep, for a great presentation. I believe now you know better technology than me of MagicTouch. So what I would like to add, the little bit small story when we were developing drug-coated balloon, and we got challenged from, particularly I'm very close friend of Dr. Bizai and Dr. Martin Leon. They asked me to develop a Sirolimus coated balloon. So Sirolimus coated balloon was a challenge because of its drug properties. You know, it's a poor in lipophilicity, and at the same time drug coated balloon, when you would like to develop when you want to have a good drug coated balloon, you have to you have a challenge to deliver the drug within 45 to 60 second max to the arterial wall and retain it for 28 days minimum to address all therapeutic window of cell cycle. So we studied a lot about the Limus during that time, that how we can develop, because everyone were trying. Everyone tried. Many companies tried. Many people tried to develop Limus coated balloon even in 2007 to 2012, but they were not getting success. So we wanted to convert this lipophilicity issue, because lipophilicity defines the adhesion property to the balloon surface as well as the vessel wall. So we wanted to increase lipophilicity. We wanted to increase the bioavailability. Compared to paclitaxel, bioavailability is very poor with the Limus. So this weakness, how we address, just I wanted to communicate to the audience, and I don't want to bore on the technology because they must be waiting for learning more cases. So we do nanotize, like we create a submicron particle from original Limus particle, that is 43 micron to 0.35 micron, and we wanted to this we decided to do because we wanted to deliver the drug to the adventitia, the depaste layer, and by that we wanted to limit the washout, means delay the washout, and by delaying the washout we wanted to increase the bioavailability, drug residence time. So that was the main weakness, where not a single company got success we developed in 2009. So then after we wanted to improve the adhesion property, the binding property to the vessel wall, as well as binding property to the balloon surface, adhesion. So we selected a drug carrier which has a two lipophilic tail and one hydrophilic head, and we encapsulate drug inside. We develop this unique coating technology. Already Sandeep explained that we have a circumferential coating. So now just what I would like to say, any questions related to technology, we would love to have from audience. And I believe Dr. Colombo has joined, right? Professor Colombo.
Just joined, and we say welcome to Dr. Colombo. We know that you were busy on the CAT Live, so I think that he is now assessing all the technical aspect, and he is going to show himself.
So what I can say as a few words about Professor Colombo, because we love him. He is a master of master and trainer of trainer. So he introduced many techniques to treat different approach. He's an innovator in clinical cardiology, and I have worked since many years now, and what I have seen always Professor Colombo is developing something new approach to now. Previously he was known as a metal jacket. He was favoring multiple stenting. Long back he introduced that concept, and now he's deleting his concept by having drug coated balloons. So thank you, Professor Colombo. We can understand that you was still busy in CAT Lab, and thank you for sparing your time. So here your fellow is there, Sandeep, and I think this is going to be a great combination between what you have taught him. Sandeep, you can taste today that Sandeep has learned properly or not. And we have a good audience.
But first of all, I'm very sorry for the delay.
No problem.
It's really we had a little bit of delay in starting a patient, but we just did a very nice ostium of the circumflex calcific with rotablation, high pressure balloon and drug coated balloon. As you know, we are not against stenting, absolutely not. Stenting saves lives and saves the future of interventionists, but there are some areas where stenting is suboptimal, and then to use other technology. So nothing against stenting, but knowing the areas where stenting does not perform as expected, and take another approach. The ostium of the circumflex that we just did is a typical example where stenting gives suboptimal long-term result. Excellent immediate, but suboptimal long-term. So can I start my presentation?
Yes, thank you, Dr. Colombo. I'll make you presenter. We know that there are, Dr. Sandeep already introduced the technology, so we can move on with the normal.
Yeah, so I gave them a brief introduction about the technology, Dr. Colombo. And so I think there are three questions that people have asked. One obviously is any comparison between the other balloons, which is currently ongoing. And the other thing is they're asking, what is the drug loss from insertion to inflation? So what is the drug loss during the transit of the balloon from your external Y connector into the lesion?
Can I take this question?
Yeah, please, Manish, go ahead.
Because just what I wanted to explain about a little bit technology. We have a lipophilic carrier, and Sirolimus drug is hidden into the carrier, as well as we have a circumferential coating, and then we refold. So 60% of drug remains hidden till it goes to the target lesion. So we have a less than 10%, 7 to 8% in transit loss.
That's
Having
well,
lipophilic carrier, which is
yeah.
unlike paclitaxel balloons, because paclitaxel you cannot. It's a variable transit loss between 40 to 60%.
Perfect. Thanks, Manish. Okay, Dr. Colombo, I think we can proceed with your presentation.
Okay, let me proceed. I need to go with the presentation mode. Okay, can you see my screen?
Yes, we can see a screen.
So indication and tips and tricks with MagicTouch. I put together 2 lectures because it's really complementary for the sake of the presentation. It's better to put everything in one lecture. I have no conflict to disclose. So let me first say a few words about DCB for in-stent restenosis. This is one of the prime indications because you don't want to put additional metal on top of metal. Sometimes you have to do because it's inevitable, but not necessarily should be the routine to use another stent instead of another procedure. And this is a classical study now, either Desire, where they did what I call optimal lesion preparation versus just balloon and DCB. And you see in yellow is a diameter stenosis at 6 months when you do angiosculpt and DCB, 35 versus 40%. And if you don't have angiosculpt, you can do cut in balloon. And the binary stenosis is really impressive, cut in half from 32 to 18. This, to me, is not sufficient because if you do IBUS, you can even do better. Size the angiosculpt or the cut in balloon optimally, dilate the stent better, etc., etc. So, but this tells you that drug-coated balloon for in-stent restenosis are not effective unless the lesion is well prepared. Improving pre-dilatation result will improve the outcome. This is a very simple tips and tricks. It's not even a tips and tricks, but is what should be done. This is a slide sent to me by Dr. Sato in Japan, and you see a diffuse in-stent restenosis. In Europe, we don't have the luxury, but if you can, you see by OCT the huge amount of hyperplasia inside the stent. They did first atherectomy, they did orbital atherectomy, they improved. You see by angiography the big improvement and the still frame of OCT. You see that there is a lot of material is gone, and then you go with DCB and implant a very short stent distally. So you use DCB only after having prepared the lesion optimally, and if you can afford, you may have to remove extra tissue, ideally with some kind of atherectomy. If you don't have, you can have a compromise with a cutting balloon or angiosculpt. We usually inflate the cutting balloon at high pressure, 20 atmospheres, because we have the stent that gives us some protection. And here is the OCT. You see the baseline, a lot of hyperplasia, some stent and expansion, but the bottom line is that here is stenosis is
I think we have a break in the audio.
Yes,
Dario?
Dr.
Yeah.
Colombo. Yes, I think that there is a problem in the audio.
Randomized study published in Lancet, basket small, open label randomized non-inferiority, 758 patients, DCB versus DES. The critique is that 25% were Taxus, but we know that Taxus is not so bad. And the 12-month events, MACE rate were similar, no difference in cardiac death and no difference in stent thrombosis. So in small vessel, I think the area is clear. I want to give one slide for thinking, and not just to transmit a message, but for thinking. The first statement is clear. When using DCB to treat in-stent restenosis, optimal angio, IVUS, or OCT results are important. But, and this statement may have a question mark, because I'm not completely sure unless we have the result of some studies we are doing. When using DCB to treat a native lesion, you may not obtain an optimal angiographic result, and the IVUS and OCT may show a plaque tear or a dissection that are a starting ground for positive remodeling. This is a theory, but I believe that when you treat native lesions and you do not implant a stent, an intimal tear, a dissection, as long as it's not occlusive, is sometimes a must, because this allows the plaque to break, the drug to penetrate, and the artery to remodel. So we have to prove with the trial that this statement is true, but I believe makes sense. So there is a difference between in-stent restenosis, where optimal result angiographically is a must, versus a native lesion, where without a stent you may not have an optimal angiographic result. Here I show you some example to transmit the concept. So I think general consideration is what I just said. In big vessel, short lesion, don't waste time, implant a stent. But in long lesion with diffuse disease, what should we do? Use the same approach and implant long stent with optimization, nothing wrong. Maybe this is the way to go. But we propose optimal lesion preparation with PDPA evaluation. PDPA is the proximal pressure and the distal pressure ratio, what used to be called the pressure gradient. Now with the pressure wire is very easy. And if you have a final gradient less than 10, means that the lesion preparation was appropriate. Here are some examples, and we are not afraid to combine. Here is a right coronary, total occluded, was reopened. We did the DS in the proximal part and use DCB in the most distal part. The movie does not run, but I have the steel frame in the center where DCB drug-eluting balloon was performed. Here is another example. Look at this diffuse disease diagonal. The LAD is a 3-5 vessel, no problem to stent. You can use a drug-coated balloon, but I don't really see a problem to stent. But the diagonal 2.5 to put a 38, maybe even longer stent, we do not say that is wrong, but if possible, we avoid. In this case, we did high pressure dilatation. There is a dissection proximally, but the pressure gradient, despite the diffuse disease, is only 11, 0.89. So we elected to do drug-coated balloon. We did this case during gym, and more than 2 months have passed. The patient is doing fine, and the diagonal did not occlude. This is another example. LAD, suitable for stenting, diagonal, more or less similar to the case I just showed. pre-dilatation of the diagonal. We had to do even a rotablation because the balloon did not inflate. We even had to use OPN at 28 atmospheres on the diagonal. Then we used drug-coated balloon. And here is the result of the drug-coated balloon with PDPA 89. Again, very favorable pressure gradient. I think the wind was blowing in the right direction, and we did the same for the LAD. The result was so good with the PDPA 95. And it's interesting that after having done the drug-coated balloon on the diagonal, the flow improved further, and at the very end, the PDPA was 95 on both branches without any stent. Very interesting. I'm not claiming that you should not place a stent on the LAD, but when the result is so pristine, confirmed by almost a normal PDPA close to 1, I would say that you can afford not to implant the stent. There is a question of late remodeling, negative remodeling, but if the lumen is so large, and especially if you have a small dissection, maybe remodeling instead of being negative will be positive. This is another example, calcific lesion of the mid-LAD requiring a long stent. There is even a lesion proximally. By IVUS, you see that there is some calcium, not a lot. We did baseline pressure gradient, which is 77. The FFR, when you have this gradient, you don't really need FFR because you already have a 77 resting gradient. So we did aggressive lesion preparation, 22 atmospheres, then approximately with a trio. After optimal lesion preparation, the pressure gradient went to 94. The AFR is 80, but the pressure gradient is very favorable. So we elected to do a DCB, and we did the final assessment with no stent at all. The IFR was 84 distally with a PDPA of 98. So with these numbers, we decided not to implant a stent. There is an area approximately where it's not suboptimal. I would not argue about implanting a short stent there, but one thing is to implant a 15 millimeter 3.5 stent, and one thing is to implant 2 very long stents to cover the whole area. This is the final angio, which is again optimal in both projections. The final IVUS shows a nice lumen. It's not a stent-like result, but the residual lumen is nice, and again, the pressure gradient is very favorable. Even proximally, there is an area where maybe, as I said, you could implant a stent, but I have really no concerns not to implant the stent in this case. So I call this an approach to limit stent length, not to go against stenting, but to be more discreet. The lesion is optimally predilated with a goal to reach a good angiographic result. IVUS or OCT are optional but suggested. Following predilatation, you may have an advanced dissection, occlusive or bad dissection, then you don't waste time, you stent. You have an optimal result with or without dissection, whatever, we almost always measure the pressure gradient. If the pressure gradient is very low, usually I say 10, but I'm really sometimes more demanding and I look for anything below 8 or 7. If the answer is yes, I go with a drug-coated balloon. If the answer is no, I go with a stent. You can decide if to place a long stent
Again, we have some problem with the audio.
Dr. Colombo, I think
data to support what I said, except some statement occasionally supported by cases. But I hope a study will. Thank you very much.
Thank you, Dr. Colombo. I think we had slight audio issue, but I think we probably got the gist of what you said in the end. Can you hear me, Dr. Colombo?
Yes, yes, I can hear you.
Okay. Thank you for a great presentation, and as usual, your cases are very nice. Well, I've got two questions to ask you, if you're okay with that. One is regarding the ISR. Now, obviously, we all use DCB for ISR. It is a known treatment. But if you have a failure of a DCB with an ISR, do you use a different DCB with, like, for example, if you have a failure with the paclitaxel, you use a Sirolimus, or if you have a failure with the Sirolimus, you go with the paclitaxel, and then you go for a stent if even that fails, or you have a low threshold for not stenting at all?
No, I think, I have anecdotal cases where I use the paclitaxel because the Sirolimus failed, but if that's the case, I go for additional stenting.
Okay. And the other thing is that when you do your ISR, you're almost, I guess, you do 100% imaging to understand the mechanism of the ISR.
Yeah. Absolutely. Imaging for, unless it's really a very focal restenosis, I think imaging is very important because you don't want you need to maximize the chance of success.
Yeah. And one last question is the lesion preparation in a de novo lesion. So obviously, I've seen that you use a lot of scoring balloon and cutting balloon. Is that you have a low threshold to use them, or you use them only if the non-compliant balloon fails to prepare the lesion? The reason I ask is the cost, because some of the centers, obviously including ourselves, when we do the scoring balloons routinely for de novo lesions, it increases the procedural cost.
No, I don't use them routinely. Honestly, I think very few things have to be used routinely. So I use, if I see the predilatation balloon is not well expanded, or especially multiple projections or I see a lot of calcium, and honestly, I have a low threshold to use a cutting balloon, but only if I really need, and also applies also to rotational atherectomy. If I see calcium, I have not a high threshold to use rotablation. I think in native lesions is important to prepare the lesion well. So but not routinely.
Okay, thank you, Dr. Colombo.
Okay, Sandeep, before moving on, there are a couple of questions by the audience. I can see that.
So after DCB inflation, so there is a question, Dr. Colombo, I will read it for you. After DCB inflation, can we do something more to the lesion, probe again or IVUS, or never touch the lesion anymore?
But I published a study, and I have some patients where for in-stent restenosis or for very high risk patient, I use first DCB and then I put a drug-eluting stent. These are patients who had several in-stent restenosis, patients on dialysis, a patient with very high creatinine. I do this combination.
Okay.
I publish a report with not bad data, but we tried to propose a randomized study, but we were always
I think I remember. Sure. I remember the study. In fact, we did the I did the study with you, paclitaxel with the Limus stent, like a synergy effect.
Yeah, but I think makes sense, but the data are only anecdotal.
Okay. The other thing I would like to say for this question is that this is my practice, Dr. Colombo. Please tell me. So when I do a DCB, after DCB, I don't take too many pictures because every time I take pictures, I enhance the possibility of dissection with a lot of contrast. So I probably take one picture with the wire still in place and a prolonged acquisition just to make sure there is no dye hang up. And then I leave for 2 minutes, and then with a second shot with a different projection, again one last injection. And I wouldn't take more pictures after the DCB because I don't want to make a dissection by injecting more contrast. Do you agree with that?
I totally agree. I think what you said is very important, and I'm going to add an additional slide in my future presentation stating what you just said.
Okay, thank you, Dr. Colombo. So Dario, so shall I do this last presentation of mine, which is basically some cases and data like Dr. Colombo just did?
Yeah,
so
yeah.
you give me the sharing.
Yes, if you want, there are a couple of additional questions that from.
So for DES-ISR, do we use the same drug? Again, we don't know this actually, whether for a Limus ISR, whether we should use paclitaxel or a Limus. We don't have the data yet. Do you agree, Dr. Colombo, for that?
Yeah, I agree. I think makes sense.
I would say I want to highlight this question because we are getting many times that since last 7-8 years or more, people are using only Limus based drug-eluting stent, and whenever you get ISR, the previously paclitaxel company were promoting that paclitaxel Limus doesn't work, that's why you have a restenosis, but it is not that. And Professor Colombo and Sandeep, you can endorse this, that when you treat this diffuse disease, only that time when you get a restenosis, you have a focal or age restenosis. This is because you have basically a drug. Limus is very poor in lipophilicity. That's why not multiple drug-coated balloons are available. So you cannot, Limus cannot diffuse well into the arterial wall because lipophilicity defines the binding diffusion power as well as the adhesion property. So and washout is very quick, and all the stent are available into the market, drug-eluting stent with Limus only coated onto the metal surface, which is hardly 14 to 16%. So you have a 80% to 100% disease area. You are delivering drug to the 14 to 16%, having poor lipophilicity. You have a less diffusion. And you cover the 40-50% or maximum 60% disease area. And it has a faster washout. Limus is very quick in washout. So what happens mainly, that untreated area comes back with the restenosis, and having all the physician, interventional cardiologists, even Professor Colombo and Dr. Sandeep, I would ask you can check this statement what I have given in your cath lab, that when you get focal restenosis with Limus, or that must be either diabetic patient has been treated or with diffuse proliferative disease. So Limus works in Limus. That means Limus was working. So yes, I think in any DES ISR, this MagicTouch is useful.
Yeah, I agree. Any comments on that, Dr. Colombo?
No, I think it's fine what you just said.
Okay, so can you see my screen?
Yes, we can see.
Okay, so in this presentation, I'd just like to show our data from a UK registry, which is currently, it was a 2-center, but this I will only show the single center registry from our center. and some cases to share with you all. So indication of DCB in my clinical practice, as alluded by Dr. Colombo, it's for any restenotic lesion, irrespective of the stent type. Obviously, these days we only see a DS ISR, but even for the bare metal, there's good evidence to use DCB. And diffuse disease like this LAD, where in the past we used to do a full metal jacket, and in fact, I have published this with Dr. Colombo, the full metal jacket long-term outcome. With a very high rates of TLR, but at the time we had no choice. But now we have the choice of using a DCB, so avoiding a long layer of stenting. And obviously important side branch osteum, as he just said, that especially circumflex osteum, which is very vulnerable for restenosis, although the initial results may look good because of the hinge point and the strength fatigue. So we tend to use more DCB in those lesions, and also any important side branch osteum like this osteal diagonal or osteal AV circumflex. The problem with these lesions are difficult to deliver a stent right at the osteum because moment you wire these lesions, the angle changes and makes the stenting very difficult to place right at the osteum. And obviously any bleeding issues, so patients waiting for a cancer surgery or any important surgery, they have a significant chronic disease, we tend to use DCB and give them just 2-3 weeks of DAPT. So we embarked this technology in 2018, and we have used in over 650 patients now. And in this analysis, I will just do this a recent analysis where we have data from April 2018 up until October 2020, during which period we had treated around 533 patients and 688 lesions. The mean age was around 65. A predominantly male population. As you can see, diabetes was present in 40% of patients, indicating most lesions we treat are small vessels and long lesions, which are seen in diabetic patients. CKD accounted for 17%, and most of the lesions were in the setting of acute coronary syndrome, 60%, and around 41% in the setting of stable angina. In regards to procedural characteristics, you could see most of them were in the de novo lesion, 62%, but we also had approximately 40% of restenotic lesions. Interestingly, as you can see here, the small vessel, which is less than 3 millimeter, was seen in almost 60% of our cases. That kind of reflects our practice with the use of DCB in our center. Pre-dilatation was achieved in 98% of cases, mainly with a non-compliant balloon and semi-compliant balloon. We also use scoring balloon and cutting balloon in a small proportion of cases. Most of them were in the LAD D1 territory, followed by right coronary and circumflex system. We also had a small proportion of cases with the vein graft and the left main stem. The bailout stenting, defined as stenting post DCB, was carried out in 7% of cases, mainly due to recoil in more than 30 cases. And flow limiting dissection in 11 cases. All the bailout stenting were carried out with a second generation proven stent. The mean diameter of the DCB used in our practice is 2.7, and the mean length is 26, indicating these are small vessel long lesions. And the median follow-up we have is 570 days, which is approximately 18 months. And you could see we had slightly higher deaths, but most of them were COVID, especially in 2020. But the cardiac death attributable to a use of DCB was very small, 2%. The target vessel MI was 4%, and the TLR per lesion and per patient was around 10%. The overall MACE rate was 11%. We had no documented case of acute vessel closure. And looking at the de novo subsets, we had 348 patients. These are the de novo lesions. The mean diameter was 2.5 and the length was 25 millimeter. The outcome in the de novo population is even more impressive, with a very small rates of hard endpoints. TLR was 8% and the overall MACE rate was 9%. So some summary, in our practice, we have seen a low rates of hard endpoints from use of MagicTouch, acceptable rates of TLR and MACE despite a complex set of patients, 40% diabetics, 60% ACS, 60% of lesions were small vessels. And in this population, the TLR of around 8 to 10% is acceptable. Results are encouraging, although we need more long-term data and also a comparison which is currently ongoing. With this, I would like to show a couple of cases. Interesting one. This exactly mirrors what we were discussing with Dr. Colombo about use of intravascular imaging. So this patient, 54-year-old man, presented with a non-escalation myocardial infarction. He had a previous angioplasty to LAD and circumflex in 2012. Now, in the circumflex, he had received a 3/0 by 30 millimeter drug-eluting stent. Now, the angiogram shows a restenosis in the circumflex stent, as you can appreciate here, but the LAD stent was okay. Now, every time I ask this question to any of my colleague interventionalists or anyone in the presentation, I ask them, how would you prepare this restenosis? They all have said maybe they'll take a 3 millimeter non-compliant balloon, and someone has said 3.5, but no one has gone beyond 3.5. So this ISR, we did an intravascular imaging. This you could see here. The stent is significantly undersized for the vessel. You will see in the pictures in a minute. And if I show you the still pictures, see the vessel is quite large and the stent is quite small. And if you look at the distal reference of the vessel, it is almost 4 millimeter, and proximally the vessel measures 5 millimeters. It's a big vessel, and the stent used was 3 millimeter, which was not optimized with any post dilatation. So obviously, with the help of IVUS, we had confidence to take a larger balloon. So we took a 4.5 millimeter NC balloon for the distal part of the stent, and a 5 millimeter NC for the top end of the stent, and then we repeated the IVUS, and you could see now the stent is nicely expanded with the 4.5 and a 5 millimeter balloon. And you see the pre and post. So this is the pre, and you could see the post. So there's a nice expansion of the stent. And with this, we now had a confidence to use a DCB because we had optimized the stent nicely. So if you had not done the intravascular imaging, you would have had a failure of this case. Patient would have come back a few months later. Now, this patient was done almost 18 months ago, and he has not come back, and we have not done any follow-up imaging, but we had an excellent result in the end. Second case is another interesting case, as again shared by Dr. Colombo. So a man with a long diffuse LAD lesion, so ischemia in this territory. So obviously we go for a strategy of stenting the top segment with a drug-eluting stent, and then going for a DCB for the distal disease. So we did 2 overlapping drug-eluting stents in the top segment, and then we did a POBA for the distal vessel, and this is a post POBA, and you could see there's a small dissection in this segment, but it is, and hence we accepted this, and we used a 2 longer DCB MagicTouch here, and we had a final result like this. Again, when you look at the stented segment, it may not look very nice, but we know from our experience these patients do have a positive remodeling, and hence patient came back for a follow-up angiogram at 6 months. You could see there's a small recoil here, but on the whole, the vessel looks much better and much bigger than what it was post-procedure. You could see that's a final result, and that's the follow-up angiogram. You could see how nicely it's all healed up and bigger. The last case is, no, I think I will, this case is all interesting, so I'll show this one. So this patient had a bifurcation disease in the circumflex and the marginal, and he also had a right coronary which was occluded. So our plan was to treat this first. So we treated the main branch with a drug-eluting stent, and the side branch, we initially wanted to leave it, but it did not look very nice. So we had to go back and do a DCB in the side branch. And this is the final result. As you could see, the stented segment looks very nice, but the DCB segment may not look very nice, but we know that this will remodel. So we left it because patient had a occluded right coronary. So he came back 3 months later for a stage PCI. And you could see now the side branch is now much bigger than what it was before. So it's possibly remodeled. So we avoided a bifurcation stenting here by placing a DCB in the side branch. So this is a post-procedure, and this is a follow-up angiogram. You could see the difference between the two, see the positive remodeling. And the last case is even more dramatic. So 70-year-old man with an inferior myocardial infarction. He had some moderate to severe disease in the LAD, but the culprit was the right coronary artery, which was quite ectatic, and you could see a blocked RV branch and also a very ectatic segment with a thrombus in it and a very slow flow distally. And if you look at the AP cranial view, you could see there's a very poor perfusion in the distal segment, and there is a thrombus here in aneurysmatic segment of the distal RCA. So our plan was to wire both the branches. So this was an important RV branch we didn't want to lose. So we ballooned this, and then we put a DCB MagicTouch here in the side branch. And here we were concerned about placing a stent because one, there is a big size mismatch and there was a heavy thrombus load. So we decided to just do a balloon with a NC balloon. And then we used a 2 MagicTouch here, and we gave the patient integralin for 12 hours, which is a GP2B3A inhibitors. And the patient had a final result like this, where there is an improved flow in the distal vessel, ECG was better, and so we stopped here. Our patient had a disease in the LAD, so he came back for a pressure wire assessment of the LAD, and then we took the picture of the RCA, and we were amazed with the result. You could see there's a nice flow in the RV branch. The distal right coronary artery is now all very well diseased, no spasms, and everything is healed up and nicely positive remodeled. The ectatic segment still remains, but because the vessel looked so nice now and patient was asymptomatic, we opted not to treat, and the pressure wire to the LAD was negative. So in summary, MagicTouch appears a promising technology initial days. Clinical outcomes from our population appears good with low rates of hard endpoints and acceptable rates of repeat revascularization. Results are encouraging, although we need more long-term data and comparison, which is currently ongoing. Thank you.
Thank you, Sandeep, for your to share your experience. Now I think that we can check if there are any questions from the audience. Maybe if something.
I'll have a look through while Dr. Colombo can comment.
Yeah, maybe Sandeep, if we can ask if they want to ask directly by using microphone. So if someone of you want, can directly handle the discussion.
Sure. There's one question called, can a packlet axle balloon be used with the Sirolimus in the same vessel treating the same lesion? If not, what about different vessels in the same procedure? Yeah, I mean, you can use both in a same vessel. Same lesion, I wouldn't recommend using 2 different balloons in the same lesion. I've not used, but certainly I've used sometimes a diagonal. I use a MagicTouch. Sometimes we don't have the size in the then we may use a packet axle. In our center, we use both technologies, although more so MagicTouch because of the deliverability and our experience so far. Do you agree, Dr. Colombo, with this?
Absolutely, absolutely. But congratulations, the cases that you showed are very teaching and highlighting. I really believe we needed to do a prospective study because we have a lot now of not even anecdotal. We have a lot of cases, and we need to confirm in a randomized study where this technology stands.
I agree with you. I think hopefully the Transform one, which is now picked up some pace, so we can get some data from it, which is currently obviously ongoing.
Yeah, both of your sites are involved in the study. You know how important it is. Now 10 patients have been enrolled, so we are moving forward with this important study also. I have one hand raised from the audience. That is Dr. Gurudevan. Would you like to talk? I'm going to enable the microphone and then. Okay. So, Dr. Mahadevan, you can talk if you want. Oh, I think that he has not question or the microphone on. So I think that there was another question before regarding comparison between MagicTouch versus other balloon, and as now also you were talking about, Sandeep, regarding the study Transform 1, is going to be promising trial because it's an head-to-head with one of the most published study with the study balloon, that is the B Brown one. So we hope to have this data very soon. Do you have you experienced something in comparison of a different balloon with MagicTouch?
We have not done any comparison in our center, but we are looking into it because we have used both the technologies, and we have a lot of data between the two. So we will, but the only problem is the follow-up duration may not be uniform. So we'll have to maybe censor the follow-up at 1 year and compare the two. That is which we are going to be doing. And also, I think there's more data coming out from Europe. I think Dr. Cortese group are doing a
CPAC study, yeah.
Yeah, CPAC study. So he's already presented that at the late breaking session at the TCT maybe, or Europe PCR. And from his data, there is no difference between the two balloons. Yeah. Have you got any comments, Colombo, about the comparison between the MagicTouch and other packet axle balloon?
I don't think. Do you have, Dr. Colombo? Do you have any comments regarding this comparison of DCB, or we are waiting for the study result just to announce the difference?
I think we wait. We have only data showing different release curves, retention, laboratory data, animal data, but we don't have, to my knowledge, any direct comparison between one drug-coated balloon versus the other. Correct me if I'm wrong, but
yeah, we're waiting for the result of Transform 1, as I said, so we will see how we'll move on. And also there are other studies on the air with the comparison where MagicTouch is going to be used, but I think that will be presented in the next upcoming Congress by Dr. Cortese and by other doctors that are working on this. But for sure, as you said, it will be really important to see this feedback directly by study result. That is one objective assessment for these type of things. And there is the last question that say, do you expect better long-term outcomes for DCB versus bioabsorbable scaffolds?
I think
I wish
you probably can explain this more, Dr. Colombo, please.
But you know, I think we can only speculate. I mean, the advantage of DCB is that you will not have the issue of dismantling. Nothing is there and nothing is going to be left there. The disadvantage is that you are not guaranteed against negative remodeling. If you have a vessel with some negative compliance and you don't have a stent, that's DCB is not sufficient. So I think, in my view, bioresorbable stenting will come back, but will not take away DCB, because I don't see the reason to put a foreign body permanent or not permanent if you don't need it. And now we have tools to know if the result we obtained is stable or not. IVUS, OCT, and pressure gradient. So I think we can make more decisions based on evidence and not just by feeling.
Yeah, I agree. I think BVS, we all had a lot of experience and some good results also, but concern is that it heals by the inflammation, so it makes more noise in the vessel, and also, as you said, dismantling is a concern, especially if it's not properly embedded in the vessel wall.
Okay, so I think that that's it. I don't know if anyone want to add something, but was a pleasure to have both of you there. The Dr. Colombo has also the possibility to assess how his fellow Dr. Sandeep is growing in his hard work that he's performing. So
Dr. Sandeep is an established consultant with a lot of experience. His fellowship are something belong to the past. He's an established consultant.
No, it's still there. It's still fresh in my. Thank you very much.
Congratulations, and sorry again for my delay.
It's okay.
Thank you very much, Dr. Colombo. Thank you, everyone.
Bye bye.
Thank you, everyone. Bye. Bye bye.